All right, next we're gonna walk through the practical knee exam. So first things first, please get them into shorts. It does no good when someone comes in jeans and knee exam. That's very hard to do. So please get them in shorts. This is a little out of order because we have to change positions a little bit, but overall the thought process is still the same. So from a seated position, first we're in the inspection, right? We're just looking at them. Hey, from there, do you see any knee effusion? The big clues that we look there is there a loss of contours? Like meaning, do you not see the patella on one side because there's an infusion there? So that's the big thing to look for. From seated, I'll do palpation on the joint line like we've talked about, and then kind of the whole peripatellar area, meaning quad tendon, around the patella, down through the patellar tendon, or anywhere that they hurt. If they're more medial, maybe go along there, along the MCL, along the pes anserine. It really depends on what their complaints are, but kind of target it towards their complaints. For range of motion and strength, pretty straightforward here, but when they're seated, what I'll do is first just have them kick out their foot to test that extension mechanism, make sure, yep, looks good. Then what I'm gonna do is I'm gonna have them kick out in my hand to test knee extension and then pull back towards their butt to check resisted knee flexion. I'll do that bilaterally to compare sides. And then I won't check knee flexion range of motion in seated position. We'll do that in supine position. And then we have neurovascular, which is essentially just distal sensation and pulses. Pretty simple there. Then what I'll typically do for my knee exam is move them back to supine. From here, I'll also do some more palpation. I'll typically do palpation of the patellar facets. When they're supine, they're more relaxed, so I can kind of move the patella more. I can see how much it tracks. And then what I'll do is essentially move the patella laterally, check underneath the lateral facets, then move the patella medially and check underneath the patellar facets. And I'll kind of pick up where I left off, which is knee flexion range of motion. What I do for that is I typically have them try to bring their heel as close as they can to the butt and then kind of compare both sides, meaning, hey, are we missing range of motion on one side versus the other? While they're laying there, I'll also do the grind test, or some people call the Clark test, which is where we're putting pressure on that superior part of the patella and having them flex their quad. And then next, we're gonna check for the ligaments, ACL, MCL, LCL, and PCL when they're at supine position. For the lock, we're gonna get that little bit of knee flexion and then try to anterior translate that tibia. Then I'll bring them over into the varus and valgus testing where I set them up with their foot underneath my armpit and check, varus and valgus stress at 0 and 30 degrees. Then I'm gonna put them back down the table and test the anterior and posterior drawer, looking for that ACL again with anterior, and then posterior drawer looking at that PCL. On top of that, then, if you're in this position and you feel like this patient is not going to be a good candidate for standing, meaning they can barely walk, they're in so much pain, I will do a McMurray's there. So we're looking at the meniscus and getting that deep knee flexion, seeing if we can have a positive for the McMurray. Otherwise, I will get them standing and do a Thessaly. And once I get them standing, I'm going to generally start with Trendelenburg just to kind of gauge their overall balance, coordination, and comfortability with standing on one foot. Because once again, if they're super wobbly or uncoordinated or can't stand on one leg, then it's going to be hard to do the other tests on one leg. If they're able to tolerate that, then I'll move on to Thessaly, which essentially we get that standing on one knee, that little knee bend, and do the twist and shout side to side, looking for that meniscus pathology. And then finally, I'll do a single leg squat, which once I talked about, which get a little bit of squat action in that knee, trying to get a little anterior translation of the tibia, looking to say, hey, does this reproduce pain, or do they have really poor movement quality? Just general screening stuff. And then essentially that's it. That's really all it takes. It's pretty quick. In that short time, we covered looking for effusions, palpation of any structures necessary, range of motion, neurovascular, and special tests for all the ligaments, meniscus, and anterior knee pathology. So obviously you're gonna have to tailor this to your patient's needs, right? Like they have pain somewhere else, then you're gonna have to palpate that specific location. But this is the general structure for how you can do a pretty quick and thorough knee exam. And it can be done in just a few minutes. However, if a patient can't stand due to pain, then we're going to remove the entire standing portion and go on to seated, supine, and then history to decide what's going on. All right, so now we're going to go through the practical knee exam. So this is the knee exam you're using in clinic. Once again, this is going to be comprehensive, but also concise. And it's going to be a little challenging here because we usually go from a seated to then supine and then standing. So there's a couple different positions, but like I said, not that hard. We're going to do it in real time right now. Okay. So looking at your knees here. Looks good, no effusion. I'm just gonna push on some spots here. Any tenderness at all when I'm pushing on a spot? Mm-mm. That's okay, okay. Then work down the patella. Patella tendon. Okay, good. Can I have you kick out your leg for me? Good, back, and then do the other one to compare. Good, now back again. Okay, now I have you push out in my hand, push out for me. Oh, no, good. Now pull back hard. Good. Same thing this side, push out for me. All right, pull back. Good, relax. Do you feel me touching you right here? Mm-hmm. And then right in you here? Yep. And then in this web space here? Mm-hmm. And then the outside as well? And the bottom of our feet, that feels okay? Yep. Okay, good. We're gonna get you off here, we're gonna get you in a laying down position, if that's okay. I'm just gonna move this. All right, so next, can I have you bring your heel to your butt for me as close as you can? Good, relax that side, do this side now. Good, perfect. You can just relax now. Good, so what I'm gonna check here is I'm gonna do patellar facets, making sure no tenderness there. On both sides, medial and lateral. Good, good, good. Awesome. Next, can I have you make a muscle for me here? I'm just pushing down. Good, fantastic. All right, now we're gonna work into our ligament testing. So I'm gonna check your ACL first. Good, fantastic. And I'm gonna bring this leg right here. I'm just gonna kind of put some pressure on that there. Fingers on. Good, and push back. Good. We're gonna check one more here. Check it out. 0 degrees. 30 again. Good. Awesome. Can I have you stand up now for me? Mm-hmm. Next, can I have you put your hands on your hips for me? Just balance on one leg. So this is normally 30 seconds here. Usually can get a pretty good gist right away. So, okay, good. We can relax there. Next, I'm going to have you in that same position, bend on one knee. I'm just going to have you bend a little bit for me. And then do side to side, twist and shout for me. There we go. Good, good. And then last one I'm gonna have you do, hands on hips. We're still gonna be on one leg. And we're just gonna do a couple single leg squats, okay? Good, give me a couple more. Good. Perfect, awesome, thank you. And that's pretty much it. Like I said, we've run through everything so far. We did all the inspection, palpation, range of motion, strength, neurovascular, and our special tests. And it gets you, like I said, the biggest bang for your buck there. So we're not gonna miss the big, bad, scary things doing that. But once again, not too bad, and we can get that done in a pretty good time. You just watched a clip from my Master MSK course. If you wanna learn more about that, click right here. And if you want more related sports and lifestyle medicine videos, click right here.